Hello everyone, happy Wednesday, because today we are going to have a learning video. My life has been so crazy with all this live special events, but I'm not forgetting about you guys. You're still in my mind, and I'm trying to post stuff that will help you guys as you practice at the clinic. And today we're going to talk about autonomic dysreflexia. Now this topic, when I was studying for MCS, this topic, I really wanted to understand it. I know it's a medical emergency. I know what you should do. I know what it looks like according to what I've read, because I haven't seen it in real life. But I wanted to know what is going on, like what happened. So today we're going to talk about that. I want to start by saying that this has a kind of like a long history. It started, or people were starting to discover this thing. This was described by Head and Riddock in 1917. And then it was described years later as a life-threatening event by many other scientists. Now, we know that after spinal cord injury, it leads to neurological injury. But let's remember that neurological injury, it's not only your ability to move or feel. It's also your autonomic nervous system. Affecting the autonomic nervous system will cause or will lead to primarily sympathetic dysfunction. And we will go over that. Now, something that I really need to here remind you is that when you're working with someone with spinal cord injury, remember there's a lot of other things that are important besides the motor part of it. And one of those things is their cardiovascular system, because cardiovascular dysfunction is often more important than motor function recovery, right? There's a lot of other things that us as PTs, we put the motor system the priority. But if we're thinking like specialists, let's remember there's more than the movement system, right? So, and initially, patients, they don't realize the significance of this, but cardiovascular disease is something that we need to keep in mind when working with someone with spinal cord injury. Spinal cord injury often leads to unstable blood pressure. And this can be low resting blood pressure, orthostatic hypotension, and even autonomic dysreflexia. With that being said, let's talk about what is autonomic dysreflexia. So this is a condition of uncontrolled sympathetic response secondary to something that's going on, a precipitant that generally occurs in patients with injury, so spinal cord injury, above or at T6. And we're going to talk about why T6. Now, patients with both complete and incomplete spinal cord injury may go through this event. However, it's thought that symptoms are less severe in patients with incomplete spinal cord injury. Now, the most prominent thing that happens when someone goes through autonomic dysreflexia is a very, very high rise of blood pressure, okay? It can go as high as 300 millimeters of mercury. Let's talk about what happens. So what happens through this process? So there's something that's called the major splanchnic outflow. It's a hard word to say. So if you find me saying it wrong, I'm sorry. This splanchnic outflow is T6 through L2. So damage at or above this level interrupts descending modulation of the thoracolumbar sympathetic preganglionic neurons that regulate vasomotor tones. So I know that was a lot of words. So pretty much if there's something going on at T6 or above, because T6 is a splanchnic outflow. So now we're talking about why splanchnic outflow, what's important about it, but just we'll go there. So pretty much it's saying if you have an injury there, it's interrupting descending control down here. Okay, so T6 is here, no flow. So this splanchnic circulation or vessels are very extensive. So these are vessels that have to do with blood flow to your liver, to your stomach, to your bowels, etc. So this is innervated by the splanchnic nerve. This splanchnic circulation receives approximately 25% of the cardiac output. So 25%, it's a lot of cardiac output, okay? Which can have a large influence of your total peripheral resistance and blood pressure. So that's why it's T6. Let's go back to what happened. So we said damage to the descending vasomotor pathways caused by the spinal cord injury leaves many sympathetic preganglionic neurons denervated. Below the injury, let's say something is hurting or there's a kink in the catheter or something going on. So this is your injury, T6 or above, okay? So there's something going on down here that will cause an afferent stimulus going up through the spinothalamic tract and the posterior column, because remember, those are your ascending tracts. So then there's a sympathetic outflow. So what does that mean? There's a release of chemicals, norepinephrine, dopamine, and other chemicals. Okay, so pretty much that's called like the massive sympathetic response. I'm going up, there's a blockage, I cannot go up, right? That release of chemicals will cause vasoconstriction, piloerection, like goosebumps, skin pallor, okay? Your intact carotid and aortic receptors will detect this thing going on, the rise in blood pressure, right? And they will make an attempt, because they want to save us. They will make an attempt to lower the blood pressure through two mechanisms. So first, I'm still holding my hand here. First, there is an increase in parasympathetic stimulation to the heart via the vagus nerve, causing bradycardia, right? Goes to the heart. But it's important to mention that this might be like a relative slowing of the heart. So it won't get like less than 60, but it will slow down your heart, right? But this drop of heart rate will not compensate for that severe vasoconstriction going on here. So that's the first mechanism. So it's like, it's not working. The second compensatory strategy is a compensatory reflex, which is like an inhibitory outflow, sympathetic inhibitory outflow from vasomotor centers located above the spinal cord injury. Now, inhibitory impulses with a negative feedback are unable to pass below the injury. So then we go back to that splanchnic circulation. So that inhibitory input cannot dilate those splanchnic vessels to accommodate all the excess blood located in the splanchnic circulation. Remember that we said the splanchnic circulation contains a lot of the cardiac output. So it cannot accommodate, because they're all like little, right? It cannot. So then again, it's pretty much the body's just freaking out at that moment. Okay, there's so many things, so many attempts, but it's not successful. Now, I know that's a lot. That's a lot of, what? Why did you say? But let's review with this little graphic that I'm gonna post right now. Here we go again. Underneath the injury, okay, there's, let's say, a full bladder or a kink in the catheter or something that's painful. That sends an afferent stimulus through your spinothalamic tract and your posterior columns. Something going on, any type of sensation, okay? That is uncomfortable. That stimulus is trying to go up the spinal cord, okay? But there's a block, let's say T4, okay? There's a block. That creates a massive sympathetic response that causes widespread vasoconstriction. So that widespread vasoconstriction causes a relative increase in blood pressure, Okay, it causes piloerection, it causes skin pallor. That hypertension is detected by your intact baroreceptors in blood vessels, okay, and your carotid and aortic bodies. They signal the brain, okay? The brain will attempt to decrease that what's going on. Heart rate is slowed down, and then there's other compensatory strategy, which is an inhibitory stimulus through your spinal cord. Now, the descending inhibitory signals are blocked because of the spinal cord injury. So that's what's going, that causes the autonomic dysreflexia. Now, let's talk about what happens if you don't do something about it, if it's going on while you're treating. The rise in blood pressure can lead to, again, uncontrolled high blood pressure, so hypertensive emergencies, which can lead to, guess what? Hemorrhagic stroke, okay? Rupture or leak in a blood pressure in the brain. Organ damage, heart attack, heart failure, kidney failure. Seizures, changes in the brain's electrical activity. These are life-threatening events. We should be treating this as soon as possible. Misconceptions, things that we might think or someone else might think but are not true. This doesn't happen in people with hypotension. Yes, it does. It cannot cause death. Yes, it can. It is not important to check blood pressure. Like, really? Sympathetic blood pressure 130, 140 is okay. No, because what if they have a resting blood pressure of 90 and now it's 140? No, you should be thinking there's something not right going on, okay? If your patient has low resting blood pressures, which a lot of people with spinal cord injury have low resting blood pressures. Baseline blood pressure may be lower for people with spinal cord injury, somewhere around 90, 110 SBP and like 50, 60 DBP range, okay? But that's just an average. There can be a rise of 20 to 40 above their normal baseline for SBP, and for DBP, there can be a rise of 15 to 20 millimeters of mercury, higher than your normal baseline, or the patient's normal baseline. The blood pressure will continue to rise until the cause of the pain or discomfort is resolved. If blood pressure is elevated and you see all these symptoms, sit your patient upright, position the legs in an upright and dependent position, remove the binder, TED, to decrease the hypertension, okay? And then proceed to find the cause. Then you should be continuing to monitor and document the blood pressure and pulse every 2 to 3 minutes. Some people recommend every 5 minutes, okay? Until those vital signs have returned to baseline. But what is the most common cause of autonomic dysreflexia? The bladder distension, urinary, anything that's related to urinary system. It's probably 90% of autonomic dysreflexia cases. Now, I'm not saying like all autonomic dysreflexia is caused by bladder, but it's the most common cause, okay? Other causes are pressure ulcer, or the treatment for a pressure ulcer. Other skin irritants like wrinkle sheets, ingrown toenails, sitting on a bump, let's say on their wallet, or something that just is uncomfortable, or anything else in the bottom, okay? Let's say for women, a menstrual cramp, or just menstruation, labor, reproductive issues that can cause autonomic dysreflexia in women, constrictive clothing, pain, surgical and diagnostic procedures, and fractures. How can we prevent autonomic dysreflexia? Ongoing care. It's the best way to prevent autonomic dysreflexia. This is something that you should teach your patient. All right, guys, that was it. It was hard. I'll see you next time. in the next IG Live talking about interventions for locomotor training with Dr. Manjiri again, and I will see you next time.